Okay, here we are, Kinesiology 230. This is chapter 22, and we're into presentation number 3. We're talking about epilepsy and cerebral palsy, and there's a bunch here to go over, so I'm going to get right into it. So with epilepsy, it's defined as 2 or more unprovoked or reoccurring seizures. And a seizure is an uncontrolled paroxysmal electrical discharge within any part of the brain that causes physical or mental symptoms, and it may or may not include convulsions. So you may have a person who is suffering a seizure at any particular moment and they're sitting quietly in their chair, but it is actually a psychological or mental seizure as opposed to a physical, what one normally would think is a grand mal seizure with convulsions. Paroxysmal or paroxysmus from Greek, it means irritation. But when you look at paroxysmal and you do the medical definition, so paroxysmal describes something sudden, say like intense, really intensive attacks or outbursts. And the idea that, it comes from paroxysmus and it's an irritation, it kind of changes when you get into the actual definition when you look at paroxysmal in how it defines or describes a sudden or intense attack or outburst, meaning like a seizure comes on with great intensity and it's kind of unprovoked and out of nowhere. Now this is a big word, this is a tough word to say. Status epilepticus. And the status epilepticus is a seizure that is abnormally long where the person does not regain consciousness in between seizures. So they may have 2 seizures back to back, but the person remains unconscious during that time. So they have this classification here in table 22.6, and they talk about some of the signs and symptoms. You might go ahead and just take a moment to pause me and refresh this here. I'm not going to belabor the points on this one, but you look at this in terms of focal seizures that'll be in one part of the brain. They may have an effect in one area, may cause certain conditions, might cause a person to have or change of consciousness or be a dreamlike experience. Then you get into generalized seizures that can happen on both sides of the brain. Notice the difference there in terms of how it could be one side or one particular area versus both sides of the brain. And they have like here, like for example, absence. These seizures are characterized by subtle body movement, etc. Atonic, drop attacks, breathe 15 seconds, cause the clients to lose muscle tone and suddenly collapse. So maybe take a moment, just kind of become familiar with some of these, especially if you're going to get into that industry or that part of the industry. In terms of when it comes to our class, research supports that exercise should be encouraged with the epileptic population, and it can help in any number of processes related to seizures. But what they do note here is when you have weight loss and a person has perhaps even 10 pounds of weight loss in the context of working out, they may, that weight loss might affect the biological availability of anti-seizure medications and increase the risk for side effects. So if you are working with a client and working on weight loss and they in fact lose weight, they need to articulate that to their doctor because they may need to change the actual dosage on their anti-seizure medication. Okay, so with cerebral palsy. With cerebral palsy, it refers to any number of different neurological disorders that can result in permanent motor impairment, and it's a non-progressive group of disorders. So what you have is damage that's caused to the either developing fetal brain or infant brain, and then the person is left with cerebral palsy as a result. But it doesn't progress, it doesn't get worse. But the physiological symptoms that manifest as a result of CP, yes, those can get worse. And they talk about 2 of the main symptoms here, which is spasticity and dystonia. And spasticity is caused by the disruptions within the motor neurons that manifest in, they talk here, speed-dependent stretch reflex that is hyperexcited, resulting in stiffness, cramping, or spasms. So you can think of it in terms of being like spastic and spasms. And then dystonia is caused by a similar disruption of the motor neurons, but it results in involuntary contractions and muscle movements due to disrupted communication between the central and peripheral nervous system. And it's a result of damage to the brain. So the way they talk about this in terms of just symptoms include disturbances in sensation, perception, cognition, communication, behavior, epilepsy, and secondary musculoskeletal problems. And so the way you have to kind of wrap yourself around this is they talk about it in 2 main overarching kind of domains or 2 main symptoms. And as a result of these two symptoms, or even take it a step further back, as a result of a cerebral palsy, you will have other subcategorizations and sub symptoms that'll manifest themselves over the course of a lifetime of having cerebral palsy. Now, with this, they give in Table 22.8 a topographical classification for different categories. And when you look at this, you have mono, di, hemi, tri, and then you get into, sorry about that, and then you get into quadriplegia down here. It's a matter of how they can organize the different types of cerebral palsy. All right, that's a little better because now you can make out all the different terminology over here. So it's a matter of looking at it in terms of, when you think of monoplegia, it's one extremity, di would be two, and it's diplegia, meaning we're looking at lower body involvement with minor upper body. When you got hemi, it could be, in terms of, I think, hemi like hemisphere, unilateral, same side, upper and lower body involvement. Tri would be three, right, like tricycle. Double hemiplegia, involvement of all four extremities, increased spasticity in the upper body, and then involvement of all four, plus the head and neck would be quadriplegia. So you have kind of this categorization as a result of the system here, and it allows people to kind of classify the different cases of cerebral palsy. But the Academy for Cerebral Palsy and Developmental Medicine has this this kind of subcategorization, if you will, that is based upon motor abnormalities, accompanying impairments, the anatomical and neuroimaging findings, and causation and timing of the actual cerebral palsy episodes. So when you look at this, this would be components of CP, and you have motor abnormalities here, and then you have anatomical and neuroimaging findings here. So we can kind of look at this and kind of go through bit by bit, maybe pause me and read through these and take a moment here, but just notice how this down here is more anatomical and neuro, and this is more motor. And the thing is, with CP, it affects the motor side of the equation, right? It affects how people can function and move. And to a certain degree, worst cases limit the ability to function or move. And I would urge you also to look at this, maybe take a moment from a sidebar that they provide in the book. It's yet another way of organizing symptoms of cerebral palsy. The symptoms can vary depending upon the functional classification of the individual. And I would also contest, like when you read into this a little bit more, it's not exclusive. There is a little bit of like, not comorbidity, but there is a little bit of symptoms that can fall into any one of these categories, but it's not universal. You might have multiple categories present themselves with a person who has CP. But take a moment here and just kind of read through this in terms of apraxia, ataxia, and become a little bit familiar. And again, if it's something where you're going to be involved in the industry and this is going to be your specialty area, then I would look at some of these research references that we have here. And you look at something like this in terms of the Gross Motor Functioning Classification System Expanded Reviews, the GMFCR-ER. And that would be a great place to start in terms of looking at these 5 levels and look at how you can categorize people with CP, where you have somebody who can walk without limitation, they have some limitations when they walk. A person could, in essence, walking using some type of handheld mobility device, like a walker per se. Self-mobility with limitations. They might have to have some power mobility. And this is the person's transported by somebody else in a manual wheelchair being pushed around because they no longer can control or have motor control enough to be move around in a wheelchair. The book also provides this. Hold on one second. Let me clean up. There we go. It's a little bit better. So notice the difference on this. When we're talking about manual ability classification system versus, if we go back one here, back a screen here, this is lower extremity function. This is gross motor function classification system. So this focuses primarily on being ambulatory and moving around, where this focuses on manual, if you will. Think hands, like in Spanish, manual or manos. This is upper body, and they have 5 levels reflecting progressive degrees of function of the upper body. handles objects all the way through handles most objects but somewhat reduced quality, and then all the way through to does not handle objects, has severely limited ability to perform even simple actions. And you just imagine, if you've ever seen people with cerebral palsy, some of the issues that they have even with their fingers and hands and losing dexterity. They do talk about cerebral palsy and having a classification system for athletics. And they talk about Cerebral Palsy International Sports and Recreation Association, CRISPRA, if you want to be like that. And they have these classifications categories which take into account symptoms, functional ability, and movement capabilities. And this is to provide a more and fair competitive environment for cerebral palsy patients who perform in athletics. You could perhaps look at this website to find out a little bit more. All right. A couple of these at the end here for your benefit, just took them out of the book. Core set of exercise tests for people with CP. You can look at, like, for example, submaximal tests up top. Then we have a classification of maximal tests here, and then anaerobic. And you have to look at this in terms of the different levels that you have for people to be able to function. So if we think of this in terms of, like, our people are like level 1, well, they can pretty much do a 6-minute field walking test, right? And if a person is perhaps level 4, perhaps not, right? Or even level 5. So this is a case where you start to look into some of these charts, and it's a little bit wonky in how they present us with the pluses and the minuses, and I wish they would have made us a little bit more user-friendly. But you can get an idea of what tests are available with the different levels of individuals. And sorry, just if you want to tie this together, the GMFCS, if we go back to here, you have this slide where we talk about the different levels here. Remember, the GMFCS is specific to regarding being ambulatory and mobility, whereas this was more about upper body with the manual ability classification system. So you would just reference back to the different levels here for placement within this grid here in terms of what is appropriate or not appropriate for your person who has cerebral palsy. All right, I cut and pasted this one in here for benefit. When you look at some of the exercise recommendations, they talk about frequency, 1 to 2 sessions per week, gradually progressing to 3, intensity greater than 60% of peak heart rate for aerobic. And when we get further down, a minimum of 20 minutes per session. Now, I will tell you, if you have people who are kind of progressed on the GMFCR, and they might be like a level 2, maybe borderline 3, they might have difficulty doing some of these with any kind of duration. But, you have to play around with what your person can or cannot do. Now we get into resistance training. Resistance training is fine. You just have to be kind of smart on what you implement and what your clients can handle in terms of handing them weights and if they're able to stand. They get into more moderate to vigorous activity down here, and then they actually have sedentary itself. So when you look at this and you look at the different exercise itself, and you have somebody who is perhaps sitting around all day and they're watching TV per se, well, you as a trainer might have a person who has cerebral palsy who does this all day long, and it's a sedentary lifestyle. And then you have people who do moderate to vigorous activity down here, right? If you look at this, well, compare and contrast that to up here. And what you're looking at is how you can incorporate in aerobic exercise and resistance training exercise based on these recommendations in a person who might have started out here, right? And I would urge you to, when you work with a client who describes that they have or discloses to you that they have cerebral palsy, again, a lot like some of the other conditions that we talked about in these presentations, that individual will be the most informed, most or best expert in the field, and I would rely on them for as much information as possible. Now, if it's an industry or a subset of the industry you want to get into, then you're looking at spending some time and energy to go out and pick up some additional certifications and credentials for the industry. So I'm here at about 15 minutes, so I'm going to go ahead and knock off. You guys have yourself a good one.